You're listening to
such a short amount of time to do it.
a Mamma Mia podcast.
From Mamma Mia, you're listening to No Filter, a podcast where people from all walks of life tell their stories very candidly and aren't afraid to be vulnerable. My name is Mia Friedman. When Caroline de Costa first started delivering babies, cane totes were used as pregnancy tests. Birth was very much a private medical matter for male obstetricians to perform. Women had no say in the way their births went, and fathers were banned from the room. Needless to say, there were no female doctors. And here's something that will make you laugh or wince. When Caroline was completing her medical degree in 1973 and decided she wanted to be an obstetrician and gynecologist, she was told no by her university because reproductive medicine was just not a woman's field. Best leave that business to the men. Caroline quite rightly thought that was bollocks, so she packed her bags and her young family and headed for Ireland, where they would train women to become gynecologists and obstetricians. 7 children, 15 books, and almost 50 years later, Caroline is an icon in feminism and medicine. She was the first woman ever to become a professor of obstetrics and gynecology in Australia, and she has a lot of incredible stories about birth. And she joins me now to share some of them. Caroline, do you remember the first birth that you witnessed?
Yes, well, I saw 2 births, which were head-first births, vaginal births, before I saw a breech delivery.
Tell me about the breech, because you
breech,
start
yes.
your incredible book with the words tiny winking anus, which I've never seen in a sentence before.
No, but that was what was happening. And I was standing wearing a rubber apron under respectful expression and a mask. It was called a labour ward at that time, not a birth suite. And birth suite doesn't mean that birth has got any sweeter. Women still work hard. And certainly that woman, who I've called Mary in the book, she was having her 4th child. She'd had 3 boys who'd come head first and then another baby. And we didn't know if it was a boy or a girl because this was 1972 and there was no ultrasound. But we could certainly see the baby's backside emerging first as part of a breech delivery.
So breech doesn't mean feet first, it means
it
bottom
can be,
first.
Yes, it means all those things. There's various kinds of breech, but it's that bottom end of the baby, not the head, which is what mostly comes first. And so there can be problems delivering the whole of the baby in a short space of time safely. And so Mary was in the hands of 2 very good midwives who are very helpful. And Dr. Jim, I've called him, and his name, I have to say, is Jim. And he was an experienced senior registrar, and he was conducting the breech delivery. And I had been interested in obstetrics and thought that was what I was going to do. But as I watched the skills of Dr. Jim in just waiting and waiting for Mary to push out much of the baby, the derriere, and then the legs, and he carefully and gently hooked the legs down. He waited for her to push out the abdomen and chest of the baby. We could see then, I was with another student, we could see that it was a girl, but he just put his hands to his lips to make it clear, don't say anything about the sex of this child until the baby's out. And anyway, Mary was shouting a great deal. She was shouting out, "Jesus Christ, I am pushing," to the midwives, yes, and other such cries. But she was working hard.
And why are breech births dangerous?
Well, because in head first birth, you have often a number of hours where the head is moulded and carefully fitted through the woman's pelvis with not a lot of damage to the head. You have one contraction and you get a very minute squashing of the head in a different direction, doesn't damage the brain. With a breech, that doesn't happen because it's the lower end of the baby which comes out first. And so if the head doesn't fit properly through the pelvis, you don't discover that until all of the baby up to the neck is delivered, and then it's hard to get the head out. Dr. Jim had had a look at Mary and he'd looked at her obstetric history, and she'd had 3 good-sized babies before, and he felt that this baby was going to come out as a breech, and indeed he then, having delivered the baby up to the neck, picked up the forceps and gently delivered the baby's head, and then said to Mary, "You've a wee girl."
Wow.
Which was great. That was a girl after 4 boys.
And you also encountered a woman at the other end of the spectrum who didn't want any medical care. She wanted to give birth by the river.
Yes,
Can you tell that
she
story?
wanted to be surrounded by nature, and her partner thought that was a good idea. Her sister did not, and her sister brought her, I'm not going to say where this was, and I was doing a locum at this stage of my career. It's a long time ago, maybe 40 years.
And this woman hadn't had much antenatal care.
She had no antenatal care. She came at 37 weeks reluctantly with her sister, and she clearly had a breech presentation at that time. And I explained to her what I've just explained to you about the head of a breech not necessarily fitting as well as it would if the baby was turned to head first. She didn't want any attempts at that. And she didn't want to have the baby in hospital. And she did not believe, and her partner did not believe, that there would be any problem.
And the partner said to you, "I'm a musician."
That's right, he said. And so I understand rhythms, so I'll be able to listen to the baby's heart, which didn't really reflect the situation and how we monitor fetuses during birth at all. He had no understanding. And sadly, she presented about 3 weeks later at night when I was on call, and she had gone into labour and she had started to push the baby out, and then she had encountered this problem of the head not coming out. And by the time she arrived, the baby was half born but sadly dead. And she was obviously very distressed by the pain and the situation. So she had to have a general anaesthetic so that I could deliver the baby. And I have to say that subsequently she showed no remorse, no regret, no insight. And she discharged herself home with her partner the next day. And we just had to hope that if she had another child, she would come for medical care.
I want to ask you about that because there are some people that see birth as a really natural process and see medical professionals or health professionals as the enemy for some reason. Do you not understand the psychology of that?
Well, pregnancy and birth are physiological processes usually, but you're reliant on nature, and nature is not always kind. And you can make a plan, you can learn a lot about pregnancy, you can learn a lot about birth and what might happen, and you can make sure that you're very healthy, that you eat properly, you exercise, you don't put on too much weight, all those kinds of things, and you can prepare yourself mentally. But you cannot totally control what nature has in store for you. And women now in Australia are choosing quite often to become pregnant, have children later in life. Sometimes they're of above average BMI, higher BMI, which can mean that they have diabetes in pregnancy or raised blood pressure, hypertension in pregnancy, which interferes with the health of the baby, with the health of the mother, and it may be recommended that the woman have induction of labour in the interests of both mother and baby, or there may be preterm birth. There are lots of things which can happen which you cannot plan for. So it's best to have an open mind. Obviously, if you can get to, after 37 weeks, go into spontaneous labour, have a short labour, not need any augmentation, not need to have an epidural, push the baby out yourself and have a normal third stage delivery of the placenta, no hemorrhage, no tears and so on, that's great. But it's not something that you can order like from a restaurant menu.
I was going to ask you if there's any such thing as an ideal birth.
Yes, there are lots of ideal births, and they are when the woman has the best possible experience and has a healthy baby and herself remains in good health, both physically and mentally. And there are lots and lots of different ways to experience this birth. It doesn't have to be that WHO definition of normal birth at all.
You speak a lot about your distaste for this term normal birth, because what does that even mean? Does it mean vaginal? Does it mean without drugs? Is there a medical terminology for what it means?
Well, it's not so much medical as defined for the medical profession. It comes from the WHO and it has been also
the World Health Organisation.
The World Health Organisation, and it has been adopted partly by New South Wales Health and so on. Does that mean that women who choose to have an epidural, who have a postpartum hemorrhage, who have an indication for a caesarean section. Are they abnormal? No, I don't think so at all. It's not a good term, and it's not something that should be held up as a model for women to somehow aspire to. It's not a race or an exam, having a baby. It's an important process. You might have only one baby or two, and you need it to be done the way that is most suitable for you, and you've had the most input into thinking about what options you have and making a choice.
You were ridiculously young when you started studying medicine. You were 16 years old. You had been accelerated through school and you were at uni at that time. You started studying medicine and you were told in the late 60s or early 70s that we don't train women in obstetrics or gynecology. Why were you attracted to that part of medicine?
Well, there was quite a lot of my life in between starting at Sydney University. I did the first year. That was 1964. It was a very exciting year to be at university.
Lots going on.
The Oz trial was happening.
The pill?
The pill was available. There was a lot of extracurricular activity which occupied me, and I was too young to be starting medicine. I didn't know if I wanted to be a doctor. Anyway, I deferred at the end of that year, and I spent nearly 3 years travelling and working, and I ended up in Europe, and I got a place in the College of Surgeons Medical School in Dublin. That was a great place to be a student. There were lots of institutions, lots of students, very multicultural and multi-ethnic, which you probably wouldn't think of when you think of Ireland, but it was. Lots of pubs, lots of after-hours parties and things like that. But it was also a very good place to study medicine, very high standards, very good teaching. You know, I really fell on my feet when I went to Ireland.
And did they admit women into obstetrics and gynecology, but Australia didn't?
Yeah. No, well, I had to get a medical degree first of all, so that was 6 years, and I qualified in 1973. And then we had to do an internship year, so I chose to do that in Papua New Guinea. I had been there as a student doing an elective, and I did that. That was a great experience as well. And then I came back. I come from Sydney originally. I came back to Sydney and did the exam, which was at that time from the Royal College of Obstetricians and Gynecologists in London. I had to do the exam at 8 o'clock at night so that it coincided with the time of the exam in London. There was no internet, you know, there were no mobile phones. We wouldn't have been able to communicate anything about the paper even if we wanted to.
So it didn't really need to be synchronised?
No, but we finished close to midnight. But anyway, I passed that exam, and so I thought it would be possible to get into training as an obstetrician and gynecologist in Sydney. But as you've mentioned, I was told we don't train women in obstetrics in Australia, where there's no place for women in practice. And it was really 97% of obstetricians in New South Wales at that time were male. It was a male bastion.
Were there other parts of medicine that women were encouraged to be in? I mean, it seems extraordinary that the specialised female part of medicine women weren't admitted to. Like, for what reason?
Well, it was male privilege, white male privilege at that time. You were a specialist if you were an obstetrician. There was a lot of money, I guess, in private obstetrics, and they were determined to keep it male. I think also they felt threatened by the idea that there might be women coming in to take over those roles and that women might be quite good at practising obstetrics. It changed over the subsequent 30 years, slowly but surely. As I came back in 1981, having trained, I went back to Ireland, trained in Ireland and a bit in the UK, and I went back to Papua New Guinea. Then I came back to Sydney, and at that time the situation was pretty much the same. Only about 3% of New South Wales obstetricians were female. But,
and why were you drawn to that part of medicine?
Well, I was qualified by then. I was very sure that that was what I wanted to do, to practice, but also to, I guess, be active in improving women's reproductive health, because there were a lot of things wrong. Laws for a start, and the availability of certain services, contraceptive services, and it was illegal to have an abortion, essentially, at that time. There were lots of problems with choice in childbirth too. So those things have all greatly improved within the last 40 years.
What were some of the laws around women's reproductive rights and choices that might be surprising to someone who's a bit younger than you or I?
Well, it could still be a problem for an unmarried mother, an unmarried woman, to access even contraceptive services from certain health centres, particularly in regional country.
Even though you would
areas.
assume that who the market would be
Yes.
for contraception
Absolutely,
is
yes.
single women.
Yes, yes. There was still opposition, for example, from the Catholic Church, and there was a stigma attached at that time, even to the pill and so on, if you were single. And of course, there was a great stigma attached to abortion, and it was not easily accessible to women, particularly outside Sydney and the coastal urban areas.
Some people might mistakenly think that if you are an obstetrician and you have chosen to be in a field about bringing babies into the world, that you might be opposed to abortion because that's meaning that there are less babies brought into the world. But that's certainly not the case with you.
Absolutely not. I believe that a woman should be able to make her own choices about whether she wants to continue with a pregnancy, whether she's able to continue the pregnancy and be a mother to the child at this point in her life, or if she cannot. And still in Australia, about half of all pregnancies are unintended, unplanned.
I've had a couple of those.
But that doesn't mean they're not wanted. Once the woman gets over the shock of the 2 blue lines and starts to think about the future and make plans. But there are still a lot of unintended pregnancies as a result of contraception not being in the right place at the right time, not working, things like that. So we need to have access to safe, legal abortion services, non-judgmental and financially accessible, so that women can make their own choices. I think that providing termination of pregnancy services, or at the very least providing information and referrals about abortion for women who are seeking that information, seeking that service, is an essential part of the role of an obstetrician and gynecologist.
You worked in Ireland for many years. Abortion only became legal there very recently. What are some of the stories that you remember about women that you saw who perhaps didn't want to carry on with their pregnancies but had no choice?
Well, at that time in Ireland, which was the 1960s and 1970s, and I was part of the women's lib movement then, the second wave of feminism, we were not thinking so much about abortion. We were thinking about contraception, because contraception was still illegal in Ireland. So I was involved in a number of events that drew attention to the lack of contraception in Ireland.
Can you talk us through one of those?
Yes. So perhaps the most interesting one is the contraceptive train. So in 1971, 47 women, took the train from Dublin, which is in the capital of Ireland itself, to Northern Ireland, to Belfast, which is in the United Kingdom, to buy contraceptives and bring them back into the country, which was illegal. And we announced that we were going to do this to the press. And off we went to Belfast and we got the condoms. We wanted to get the pill, but we didn't actually have a prescription. So we got aspirin and we thought that the Irish Customs officers wouldn't know the difference. And they didn't. So we came...
So you wanted to be caught.
Oh,
the whole
absolutely.
point was that you were doing it.
Caught, and we were demonstrating that Irish
so it was
women,
a protest.
Irish couples were not able to access contraception in Ireland, and it was high time, that they could do this in their own country and make their own decisions about how often they wanted to.
So what happened when you got to the border?
So when we got to the border, which was actually in the station in Dublin, the customs officers were waiting. And we were quite nervous, but they were much more nervous, and they were pink with embarrassment. And some of them had never seen a condom.
Some of these men had never seen a condom.
No, they hadn't. They didn't really know what they were looking for. And, they corralled us into a bit of the station, and I had my son with me, age 2, and this very young customs man, he wouldn't look at me. He was bright pink. He's looking at his feet, and he said, "Miss, have you got any of them things?" And I said, "Yes," and I threw down several of the condoms. We didn't show them all of them. We took some into Ireland. And he just didn't know what to do. And that was the situation with most of them. They didn't really know what to do with us. The press loved it, and it was very much reported and discussed on the radio, on TV, over the following weeks. And it was one of the things that led to the founding of the Irish Family Planning Association. And I later worked in their clinics, which were a little bit dicey because they weren't quite legal. And so we always knew where the back door was in case we were raided. Sadly, we were never raided when I was there.
Sounds exciting.
I can't tell you, yes. But gradually, contraception arrived in Ireland. It took, I think, about 10 years from then. By then, I had returned to, first of all, Papua New Guinea and then Australia. So I wasn't directly involved in the successful attempts to introduce abortion, to decriminalise abortion in Ireland. But I was very supportive of them. Now, the contraceptive train, I didn't think about it for years and years. But in 2015, I got a phone call from a woman in Dublin, a theatre director, and she said, "We've made a musical about the train." And at the other end of the phone, I couldn't stop laughing. I thought that was just hilarious, yeah. And the people who made it were from Riverdance. It was very slick.
Wow.
It was wonderful. And I didn't think you've got enough material to make.
Complete with Irish dancing.
Lots of dancing, yes, yeah.
Wow.
And priests and, wagging their fingers and customs officers and all that kind of thing. So it was premiered in Limerick with a very big Irish party.
Much Guinness
I was invited
drunk.
to that, yes, in true Irish style. And then it ran for a long time, much longer than they thought it would. It was extended.
Wow.
And it was very popular in Ireland. I don't think it really would extend to Broadway. You need to be Irish to understand the history. Yeah.
I'm Mia Friedman, and you're listening to No Filter with Caroline de Costa. You mentioned having a toddler. You became an unmarried mother at age 20 and went on to have 7 children. You were married for 6 of them. What's it like giving birth when you're an obstetrician? I know for the first one you weren't, but when it's your job, how does it work when it flips the other way?
Well, because I'd had the first one and I knew nothing, there was no antenatal education at that time, I got Dr. Spock's book. I bought it second-hand in a bookstore.
And he was like a baby expert,
yes,
right?
That's right, yes. So I thought I'd better read this. And I got it for 6pence. And I got onto the bus in Ireland and opened it. And it was missing the first 16 pages. So I never really found out what Dr. Spock said about birth. But I suppose I was young and I had made the decision that I was going to have the baby, although I knew nothing about babies. So I was kind of learning on the job. And because I'd had the first one, I guess it wasn't so difficult.
What were your births like?
Well, the first one took a very long time because this was 1968 and there was no augmentation.
What's augmentation?
Augmentation is using the drug Syntocinon, which is...
To hurry things along.
Yes, and we often use it these days. I went into the hospital on a Wednesday afternoon and I gave birth to Jerome on the Saturday.
Oh, wow.
So I was more or less in labour most of that time. And that's what labour used to be like for some women.
No pain relief?
Oh, yes, I had pethidine, yes. Oh, that was wonderful.
Did you like that?
I did like the pethidine, yes. And then when he was actually born, he was a forceps birth and I had chloroform, which was amazing. And I could understand why Queen Victoria loved it.
So she used that to give birth to her many, many children?
Yes, but not until she got to, I think, the third one. She hated the first 2. She hated childbirth.
As you would with no pain relief.
Yes, that's right. But she got chloroform and after that she said, it's wonderful. Yes, and of course other women then began to use it and realise, well, you don't have to go through this business of no pain relief during labour.
So when you're an obstetrician, do you have to have an obstetrician or can you be your own obstetrician?
Oh, you can't be. No doctor should be self-medicating, no. I've had wonderful obstetricians.
And is there a lot of pressure being an obstetrician for an obstetrician?
Oh, I think there is, yes. For various reasons. I had the children in 2 tranches. The second lot, I had my youngest son when I was 41 and my youngest daughter when I was almost 45. So that's quite a long...
You gave birth over a period of 25 years.
Yes, and things changed a lot.
What did change over that time?
Oh, well, the possibility of epidurals, but I didn't have an epidural by the time you get to kind of the number of babies I'd had. I didn't need an epidural.
Why?
They would...
Do they just
well,
fall
they're much
out?
shorter.
I mean, the baby falls out, not the epidural.
Well, not exactly falls out, but labours are quite short. Yeah, so I was always quite happy to have pethidine again. I am not addicted, I hasten to add.
You're like, has anyone got any of that old chloroform lying in the back of a cupboard?
No, chloroform's gone out. And now when I talk to anaesthetists and say I had chloroform, they say, oh, you could have died. And I say, well, I didn't. It was commonly used. It was very successful and no problem.
So tell me about birth plans, helpful, unhelpful?
Well, I'm not against birth plans. One of my medical students, and I've been teaching medical students in James Cook University for 17 years, a male medical student, a very good student, made a very astute remark. He said, I've only seen birth plans done by women who are having their first baby.
So true.
I think that once you've had the first one, you realise that things may not go according to the plan, and you're probably so busy dealing with the first child anyway that you don't make a plan. You just hope that everything is going to be fine. And I think a birth plan helps you and your partner and your family and your doctor know what you'd like and how you'd like it to be. But you shouldn't have a birth plan and think that because you've made the plan, that is what is going to happen. You need to keep an open mind about what nature will do and how you may have to have an assisted birth in some way. You may end up having the recommendation for caesarean section. So I think you need to be prepared for those things and able to listen when those things are recommended to you when you actually get into the birth suite.
In terms of how we view birth and what you've seen change over the sort of 50 years or more that you've been practicing, do you think we're at peak birth experience? I sometimes think, and I was like this myself for my first baby, as you just quite rightly pointed out, a little bit like a bride. They're not having a marriage, they're having a wedding. And I very much felt I wasn't having a baby, I was having a birth. And so there was a lot of focus on that birth, and a lot of women talk about what they want and how they want it to be. And do you think that that was something that women in the 60s, 70s, 80s considered?
No, I don't think so. I think what you're saying is it's an experience, and the birth experience, of course the birth experience is important. We don't want women to have bad experiences. But when I think about the woman, Mary, who had the breech as her fourth baby, I think she took on board the fact that she had a breech. She was going to the hospital. She was going to have the baby. She hoped to have a girl, and that was about it. I'm very sure she didn't have a Shao-Ti. Having had three boys and living in quite a poor part of Dublin, she wanted to have a healthy baby, and that's what happened. And there certainly is now a lot of attention, and it's partly, I guess, because there are now choices for women. They can decide that they're not going to try to become pregnant until they have established themselves in a career or travelled or followed certain plans. And so having a baby becomes a bigger kind of, not hurdle, but experience that they want to have. And I think that sometimes too much attention can be on the actual birth itself rather than thinking, well, I'm going to have a child who will be part of my life, probably for the rest of my life, but certainly for the next 20 years or so.
How have you seen the role of partners change over the decades?
Well, when I began in Ireland, there weren't partners, there were husbands. And sometimes the husbands were kind of mock husbands. They had to pretend to be married.
Why?
Because it was really important to be married if you're having a baby.
So they were like stunt husbands, or were they just like boyfriends?
Sometimes they really were the partners, the actual biological partners, and sometimes women would perhaps say they had an absent husband and they would have got a ring from somewhere to show that they were married if they were appearing in the public health system in Ireland. There were also mother and baby homes where so-called fallen women, single girls, single young women who were pregnant, who had sought the help in inverted commas, of the Catholic Church, were fed into a system which supported them but made them work while they were in the mother and baby home.
You went as part of research for an article.
Yes, I did.
Not when you were pregnant yourself, but what you pretended to be. What did you find out?
I was pregnant.
Oh, you were?
Yes, it was when I was having my first baby, and I was a single mother. We were called unmarried mothers then. But I was also a medical student, and my family were not in Ireland. I'm not Catholic, so I didn't feel constrained.
What did you learn when you went there?
Well, first of all, they said, we'll give you a different name so nobody will know that you are here. I was going to be called Mary Mulcahy, and then we'll arrange a place in the mother and baby home outside Dublin, and you can be there, and we can also send letters from England or somewhere if you want your family to think that you're somewhere working.
Like studying or working abroad?
Yes. Well, I didn't need any of that. But it was interesting because I was writing an article about it, pointing out that this was really atrocious, what was happening to young women in this situation, because almost invariably they had their babies taken away. Sometimes they didn't even see them, and they were adopted. And then the women were just really turned out onto the street to adjust to what had happened to them, to go back to their families without the family knowing that they had had a baby. It was an absolutely atrocious situation. It was here too.
I was going to say, towards the end of your book, you have a story about a woman called Farah that you met. Can you tell the story of Farah?
Well, Farah came from a Middle Eastern country to join her sister and her sister's family.
This is in Australia?
This was in Australia. She presented in labour, and her sister brought her to the hospital because she was in pain, and the midwife who saw her realised, of course, that she was pregnant and in labour. And I was the doctor on call. I came to see her, and the sister was horrified, not so much at Farah, but because of her own husband would throw Farah out of the home. She would have brought dishonour on the family.
Because Farah was only 17 and the sister said to you, but she's a virgin, she can't be pregnant.
Yes, so the midwife said, I don't think so, But the main thing was to look after her, and she had the baby, a boy, and she looked briefly at him, but she was crying and she just turned her face away. So then we had to keep her in the hospital and get her to see a social worker and get the baby adopted and get the papers done without the husband becoming aware of this.
Who was her brother-in-law?
Her brother-in-law, yes. And then she went home with no knowledge in the family of what had happened to her and no really psychosocial support for her after that. Must have been a terrible experience for her.
So as an obstetrician, there is so much emotion around people's stories. You see people in the most vulnerable moments of their lives, their happiest and sometimes their most tragic. When something goes wrong during a birth, are there stories that have stuck with you?
You have to remain professional at all times, but you obviously are involved, particularly if you look after a woman during pregnancy and it's been complicated and you manage her care and she has a healthy baby. And that is just such a joyful experience. But of course, sometimes there is not that outcome. Stillbirths still happen in Australia, sadly. And that kind of situation particularly, it can happen. It can be unpredictable, and that is the most difficult situation when something happens that you really hadn't anticipated and it happens suddenly. And then you have to explain to the woman as much as you know about it, explain that there may be tests which will be done to see what has happened with this stillborn child, what has been the cause, what advice can be given. There may be feelings of blame on the part of the parents, and you may need to spend a lot of time debriefing people, arranging for them to see grief counsellors, social workers, psychologists and so on. You need to be involved in those things, but you need to have a little bit of professional distance. You cannot involve your own emotions too much in those of your patients.
What are some of the things that happen differently when a woman has either given birth to a baby that was stillborn or needs to deliver that baby? I've heard that a certain sign is put on their door so that the midwives and nurses and attending doctors know what's happened before they perhaps go into the room. Like, what's the vibe in the room when that happens?
Well, I have to say it's awful, really. It's an awful situation for the woman, for her partner, and for the family and for the doctors and midwives to be present at. And it is very important that the woman is separated from women who are having healthy, crying babies. It needs to be somewhere else in the institution. And obviously that woman needs a lot of help. But it's a very silent process, really. And you'd also want the woman to have as much pain relief as she could in that situation, and then that she's able to hold the baby. If that's what she wants, you talk to her beforehand about what she will experience and what she wants to do in terms of looking at the baby, keeping the baby with her or not after the baby's born. A lot of effort goes into it on the part of the attending staff. And certainly, yes, keeping other people out is very important.
What are the relationships like between doctors and midwives?
Midwives look after women who have a normal pregnancy and normal labour, normal birth, so to speak, physiological birth and a physiological third stage of birth, and they don't have hemorrhages afterwards. And they need to be able to see when things are becoming abnormal. And I'm using normal here in a broader sense, and to hand over or to alert doctors to the fact that the woman requires some attention from maybe a junior doctor or from an obstetrician. And it's best when midwives and doctors are working in a complementary fashion. And sometimes doctors can hand the care of women back to midwives, but often it should be a joint process until the child is safely born and the woman is in good health as well. There are sometimes turf wars between midwives and doctors. We certainly know that that is the case. I haven't had too many bad experiences myself. I love midwives, and I've always found them extremely helpful in teaching me, in assisting me in various ways. In Ireland, in Sydney, in Papua New Guinea, in Cairns. I think that some midwives, just after they train and they go into practice, and mostly they haven't had children themselves, perhaps come with received ideas about childbirth. But I find that as midwives continue in their profession, and they perhaps not older, but more mature, more experienced midwives are much more accommodating with the medical students, and there is much less unhappiness. What's the word I want?
Resentment?
Much less resentment and much less carving out of territory. You can't come into the room because I'm the midwife and I'm looking after her, or that male medical student can't come in, or even that female medical student can't come in.
Are people having more and more people at their birth? Have you seen a trend towards that?
Well, that came to an end with COVID.
COVID notwithstanding.
Yes. In public hospitals, it's usually limited to one or two, and you can't take the family dog.
It's a shame, really.
Yes. Many women have their partner, male or female, but sometimes they prefer their mother or a friend, or the partner is no longer in their lives, for example. It's good to have somebody there supporting you who understands who you are and what you would like.
There are no photos of my birth when my mother gave birth to me, but now, you know, everything is content, isn't it? And I noticed that in the photos taken often with newborns that either celebrity releases or even a regular person, there's a lot of makeup, they're quite posed. Like, what have you seen with the difference in how people capture those happy moments?
Yes, there are amazing photos of people all dressed up having had a baby. They must have a makeup artist somewhere in the wings and someone to fit clothes onto them, because after you've spent 8 or 10 hours in labour and then pushed out a baby and maybe had some pain relief and you're totally exhausted, you don't look like that. But you look contented.
Are people wanting to film their births more?
Oh, absolutely. Yes, videos of the whole thing, yes.
And what challenges does that pose for the medical team?
Well, it can be difficult if they get in the way. And also there are legal aspects too if they interpret things wrongly. So video is not usually allowed in operating theatres, although photos of the baby after it's born, he or she is born.
Or while it's being born?
Yes. Still photos are possible.
What does it feel like to perform a caesarean?
Well, after you've done a few, it feels pretty straightforward. Most of them are straightforward.
Is it like rummaging in a drawer?
Oh, no, there are layers. You know what you're looking for.
But I've heard women who, I haven't had a C-section, but I've heard women who have explain the feeling as being like someone's rummaging around inside you.
For the woman, yes.
Yeah, so what does it feel like for you who's doing the rummaging? I mean, that's obviously it's a little bit more technical than rummaging.
Yes, well, there are certain layers and you go through the layers, and as an obstetrician you learn what the layers are, and you have to approach them in the right manner with the appropriate instruments and minimise bleeding while you're going. But there are about 5 layers to go through, and then you find
Hit
the baby. Find the baby, usually head first. So sometimes you see the face looking at you, sometimes you see the baby's hair.
Wow.
And then you lift the head out. It's usually a head first, although of course it can be a breech. And then you gently lift the rest of the baby out. And usually then the anaesthetist has had a drape separating the mother from the initial part of the operation. And the partner is usually sitting down next to the mother, and then you can pass the baby over to the mother so she can see the baby to start with and hold the baby. Generally then a midwife takes the baby over to a resuscitation table to make sure the baby's warm and breathing and turning pink with the mucous membranes and is healthy. And then the baby can go back to the mother and even be put on the breast while the doctor is sewing up the caesarean. Now, some caesareans are very difficult, and sometimes we recommend a general anaesthetic to a woman if we think that there may need to be extra surgery or it may be particularly difficult, so that there's not that tension there. Because the obstetrician too needs to be able to perform competently and not feel terribly stressed by the situation. But it's not terribly common to have a general anaesthetic.
How common is it for partners to faint?
Well, that's why we tell them to sit down. Yes. And I've seen guys who stand up and faint. And so the midwife who's there to take the baby is usually pretty ready to grab a guy who does that and say, just sit down, please. Yeah.
There's a lack of inhibition when a woman is in labour, in my personal experience. What are some of the funny things that you might have observed over the years when a woman is in that part? I mean, I think I asked my husband to take me out to the car park and run me over with the car just to put me out of my misery when an epidural wasn't available. What are some of the things you've heard women say or do?
There's a lot of abuse of their partners and husbands for putting them in that situation. Sometimes they are calling out for their mothers. There's a lot of invocations to the Virgin Mary, to Jesus Christ, etc. I put some of those in the book.
Yeah.
Generally cursing for the situation they've got into. That's usually towards the end of the first stage. And then, of course, once the baby's born, it's completely different. They're so overjoyed by the arrival of the child. So there's a big contrast between before and after. Yeah.
I also recall offering to propose to every anaesthetist who's come to administer an epidural. I'm sure they're used to that.
Oh, yes. Anaesthetists are very popular once they get the epidural in, yes. I've also experienced the woman actually biting my arm, with the effort of pushing. Yes.
Wow.
And trying to dislodge her teeth was just not possible. So, like being bitten by a small shark.
And Caroline, do you still have that feeling of wonderment?
Oh, yes. I don't regret for 1 minute being an obstetrician. And I would say really I've enjoyed every minute of it. It's always a joyous thing to see a baby safely born.
Thank you so much. Thank you for listening to this No Filter. What a legend. I'm talking about Caroline, not you, but maybe you're also a legend. I'm sure you are. Find Caroline's book, The Women's Doc, her incredible memoir, at any good bookstore, and we'll put a link in the show notes. And if you're in the mood for another podcast, have you heard about The Undone? It's a Mamma Mia podcast with some young people hosting it. Em and Lucy are two 20-somethings who are figuring out dating, careers and life. Here's a taste.
So this is a list of things where you definitely have to get rid of your friends. No questions asked, okay? So get rid of your friends if they use you as a soundboard. Get rid of your friends if the give and take isn't equal, if you realise that they know everything about your life but are hiding things from you.
But also the other way around. Like if someone is just dumping on me every time I see them, no.
No, get rid of them. Get rid of your friend if they buy you a candle for your birthday.
No, I don't agree. I love
Candle
candles.
is the most generic gift. You know it's the gift you give someone because everyone likes candles.
Check it out wherever you get your podcasts. The assistant producer of No Filter is Lucy Neville. The executive producer is Eliza Ratliff. I'm Mia Friedman, and I'll see you on Mamma Mia.
Mamma Mia acknowledges the traditional owners of the land we have recorded this podcast on, the Gadigal people of the Eora Nation. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander cultures.